I'd like to give a huge thanks to donors, the Genetics and Genomics Services, as well as Ms. Nancy Parkhurst. And these donations are really helpful to us in sustaining this program, and we're really thankful for their generosity. So we have two speakers tonight, and Dr. Robert Voigt and Dr. Chaya Murali. Dr. Voigt will be the first speaker, so I will introduce him now. Dr. Voigt completed college at Johns Hopkins University, went to medical school at New York University School of Medicine, did his pediatric residency training at Baylor College of Medicine, and developmental pediatrics fellowships at the Medical University of South Carolina and at Baylor College of Medicine. He was previously on the faculty of the Mayo Clinic in Rochester, Minnesota, and he served as the program director for the Pediatric Residency Training Program at Mayo. Since 2010, he's been the professor of pediatrics at Baylor College of Medicine, and he's the Leopold L. Meyer Chair in Developmental Pediatrics and Director of the Meyer Center for Developmental Pediatrics and Autism at Texas Children's Hospital in Houston, Texas. Dr. Voigt has served on many national committees, including the American Academy of Pediatrics, and was the editor-in-chief for the first and second editions of their textbook, the American Academy of Pediatrics textbook in developmental and behavioral pediatrics. So welcome, Dr. Voigt. Thank you very much for speaking this evening.
Hey, thank you very much for inviting me. Let's see if I can share my screen. Oops. Okay. Did that work? All right. So I did just want to correct one part of my introduction. Susan got it right, but the slide didn't. We're now the Meyer Center for Developmental Pediatrics and Autism. There's no separate Autism Center and Meyer Center. And by the end of this talk, you'll understand why, because autism is certainly just one of many developmental disorders that we evaluate here at the Meyer Center. For continuing medical education meetings, we always have to give a disclosure, so I left this slide in. My only outside interest is I edit the developmental behavioral pediatrics section for a online publication called Up to Date. And I'm not going to be talking about any off-label uses of medication. So I just wanted to start off with a review. Why did we come up with this title about a checklist? And it's really because of a manual called the DSM that first included autism in 1980. And that ever since this manual came out, I think the general public, rather than thinking about autism as a medical issue, thinks of it as a checklist. And I think many medical providers think the same way. And just so you know what this DSM manual is, it stands for the Diagnostic and Statistical Manual of Mental Disorders, and it's published by the American Psychiatric Association. However, I think what a lot of people may not know is the criteria for each disorder and the disorders that are included change over time and with each new publication of the DSM. So autism didn't appear in the DSM until the DSM-3 in 1980. So, a lot of people are concerned about the increased prevalence of autism over time. And one of the main reasons for that is, before the DSM-3 in 1980, you could argue that the prevalence was zero because it didn't exist in this manual. Another thing is, and I'll illustrate that in a second, the criteria for autism have gotten much easier to meet over time. And we know with any developmental problem, there's always a lot more kids who are mildly affected than more severely affected. And so as the criteria have gotten easier to meet over time, the more prevalent, more mildly affected kids have been identified. So that's probably the main reason why the prevalence of autism has increased over time. So to give you an example, in the DSM-3 in 1980, the criteria to be diagnosed with autism were pretty significant. This is how it was worded in the DSM-3, that autism was a pervasive lack of responsiveness to other people, gross deficits in language development were found, and bizarre responses to various aspects of the environment. So you read that and you think, wow, that there's not a whole lot of kids that are going to meet those criteria. But with the DSM-5, the most recent version, which was published in 2013, the criteria have changed to just persistent deficits in social communication and social interaction and restricted repetitive patterns of behavior, interests, or activities. So this, seems to me much easier to meet those criteria. And so the criteria have really gotten easier to meet over time. The other thing that the DSM has popularized is kind of this checklist way to make a diagnosis, which is very different than most things we do in medicine. In the DSM-4, the preceding document before the current DSM-5, autism was included in a broader category referred to as pervasive developmental disorders. And in order to meet criteria for a pervasive developmental disorder, you had to meet at least 6 of 12 checklist items. And in that checklist, you had to meet two items from column A, which represented impairment in social interaction, one from column B, which represented an impairment in communication, and one from column C, which represented repetitive or stereotypic behaviors. And once those 6 of 12 items were met, the diagnoses that you could make were autistic disorder, Asperger disorder, or if you really didn't quite meet the criteria for either of those, or your symptoms were more mild, you met a criteria called pervasive developmental disorder not otherwise specified. So with the change to the DSM-5 in 2030, they've made it a little bit easier because they've gotten rid of the diagnoses of Asperger disorder and PDD-NOS, and everything now is just autism spectrum disorder. But they still included a checklist that to be diagnosed with autism spectrum disorder, you need to meet 3 out of 3 items for deficits in social communication and social interaction, 2 out of 4 items for restricted repetitive patterns of behavior, interest, or activities. And like I said, there's just a single diagnosis now, autism spectrum disorder, which does recognize autism as a spectrum. We always tell the residents when they rotate with us, if you've seen one child with autism, you've seen one child with autism. This type of diagnosis is very different than most of medicine. If you have sickle cell disease, every single person with sickle cell disease has the same mutation and the same diagnosis. And autism, as Dr. Murali will talk about later, can be caused by multiple different things. So no 2 kids with autism are exactly the same. The DSM-5 does talk about specifying whether the autism spectrum disorder is with or without a language disorder. And that's how they sort of included Asperger syndrome. So what used to be called autistic disorder is now called autism spectrum disorder with a language disorder. And what used to be called Asperger syndrome is now autism spectrum disorder without a language disorder. So that's really the separation of those two. In the DSM-5, it's also supposed to be specified whether autism occurs with or without an intellectual disability. About 40%, 30 to 40% of kids with autism also have an intellectual disability. And there's also a specification as to whether the autism spectrum disorder is associated with known medical or genetic conditions. And I'll talk about this a little bit later, but really every kid with any kind of developmental disability has 2 diagnoses: the descriptive developmental term, autism spectrum disorder, and then the etiologic diagnosis, if we can figure it out, the genetic diagnosis or some other neurobiologic diagnosis. And then finally, the DSM talks about specifying the severity level of the autism symptoms. And this is something that at our center, we tend not to do very much, especially among the younger kids. When you look at this, it says severity level requiring support. And what 2-year-old does not require support? So they're not very predictive, and we tend not to use that. So my objective really, I always tell the residents the first day they rotate with us that child development is the basic science of pediatrics. If you're not interested in child development, you shouldn't be a pediatrician. And since it is the basic science of pediatrician, I'm always trying to give in every talk a mini fellowship in developmental pediatrics. So anybody interested in pediatrics is going to get a mini fellowship in developmental pediatrics in the next 25 minutes. But the main objectives are to describe how autism is a descriptive developmental diagnosis within the spectrum of neurodevelopmental diagnoses. And Dr. Murali will talk about the multiple etiologies. And the second is, rather than thinking of autism as a checklist, to think about how the atypical behavioral profile observed in autism can be explained by its atypical developmental profile. And by atypical, I use that word really in a statistical sense, that you'll see that most kids with developmental delays have fairly even delays across all streams of development. We know just statistically that the more different you are in any two areas of development, the fewer people in the population have that pattern. So when I'm talking about atypical, what I'm talking about is a statistical atypicality. Like the kids develop in a way that's different than most other kids, so you expect their behavior to be different. So the first thing we need to know about then are there's basically three ways you can have a developmental problem. The first is developmental delay, and usually everybody knows what that means. Just means that you're acquiring skills more slowly than typical. And like I just said, the most common pattern of developmental delay is a fairly global delay across all areas of development. Developmental dissociation is the second problem you can have. So if I said it's more common to be globally delayed, then it's unusual or atypical or different statistically to have developmental rates that are significantly different in two streams of development, to have language development that's lagging behind visual problem solving development, for example. And so developmental dissociation is less common and therefore more atypical than global developmental delay. And then the third problem you can have with your development is developmental deviation. And that's the least common and most atypical pattern of development. What developmental deviation is, and I'll give you an example, is when you acquire developmental skills in the wrong order. Most development is very sequential. You sit before you pull the stand, before you walk. Whenever that sequential pattern comes in the wrong order, that's also something to be concerned about developmentally. All right, so we'll go through these a little bit quickly. I'll try not to talk too fast, but like I said, developmental delay is a significant lag in one or more streams of development and most commonly represented by a more global delay affecting all streams of development. So here's an example, our first case, and it's a 2-year-old boy who goes to their pediatrician, fails a developmental screen, and their parents are most concerned that he's not talking. So from a medical perspective, the first thing we would do is to take a history. Whenever you go to the doctor, we never just do a test. We always get a history first, and it's that the medical way of making a developmental diagnosis is to combine the history with direct observations, maybe a developmental test. But the first step is the developmental history. We get 85 to 90% of the information from the history. So if we just look at the different streams of development, we start off with gross motor usually when we take the history because parents are good at remembering it. Every parent remembers when their kid walked, but very few are going to remember when their kid first alternated their feet going up and down stairs unless it just happened. So we focus the developmental history on things that are easily remembered and things that just recently happened. And then, it makes every parent a good developmental historian. So this child sat at 1 year. And when I have a big audience that I can see, I say, what do you think about that? But since we're doing this virtually, I'll tell you, well, that's pretty delayed. Kids usually sit around 6 to 7 months. So it's, this kid sat at about 50% the expected time and is just starting to take independent steps. So most kids start walking at around 12 months. So this kid is 2 years old. So this means with just those two historical questions, we get this pattern that the gross motor development has been delayed at about 50% the expected rate. And in terms of developmental delay, we usually get concerned when the milestones are occurring at less than 70% the expected rate. So, I know when I give this lecture to the residents, they're usually very surprised, but this doesn't surprise me because I just said most kids who have developmental delays are delayed fairly equally across all developmental streams. So the chief concern in this patient is he's not talking, but usually the chief complaint in developmental pediatrics is just the tip of the iceberg, and there's more underlying developmental problems. So it's not so surprising to me that this gross motor development is coming at 50% the expected rate. If we look at visual problem solving, the child began reaching for objects at a year. Kids usually do that around 5 to 6 months. So again, 50% the expected rate. Just started to uncover toys, that's about a 10-month thing. And just started to release objects, that's a 12-month thing. So our nonverbal visual problem solving is also coming along at 50% the expected rate, which again would be the most typical pattern. And then speech and language is the most concerning, but as we go through that, began babbling at a year, most kids will babble at 6 months, so 50% the expected rate. Just started using a specific mama and dada, they referred to mom and dad, and that's about a 10 to 12 month thing, and just started pointing to indicate needs, so that's also a 12-month thing. So just these couple of questions tell us that this child has been acquiring developmental skills across all developmental domains at about 50% the expected rate. So our diagnosis, if confirmed on our evaluation, would be global developmental delay. And that would be the most common reason for a child to present with not talking. Statistically, that's the most common thing. All right, so now we'll talk about developmental dissociation. And remember, that's a difference between the developmental rates of two streams, with one stream significantly more delayed. Whoops. And dissociation is atypical, meaning it's less statistically prevalent compared to more global developmental delay. So here's a case number 2, 2-year-old boy fails a developmental screen. And again, the parents are most concerned that he's not talking. And with our developmental history, start with gross motor. Well, he walked at a year, that's right on target. Ran at 18 months, that's great. Just started to jump, getting 2 feet off the ground. That's a perfect 2-year-old milestone. So in contrast to our first patient, this child's gross motor skills are age appropriate. Then when we look at the visual problem solving, nonverbal reasoning, looking at something and figuring it out. He intentionally released objects before a year, that's a year-old thing, that's 100%. Scribbled soon after a year, and that's really a 16 to 18 month thing, and can now imitate horizontal and vertical strokes with drawing. That's a 2-year-old thing. So again, that's totally age appropriate. So the gross motor is age appropriate, the visual perceptual fine motor is age appropriate. But we go to the language and we get a very similar history as the first child. Began babbling at a year, that's a 6-month thing. Just started using mama, dada, does not say any other words, so that's 11 months, you start saying other words, but did just started following gesture commands, which is a 12-month skill. So these speech and language milestones have been acquired at 50% the expected rate. So this child is delayed in his speech and language development, but almost as importantly, his speech and language development is dissociated from the rest of his development. So this child's diagnosis would not be global developmental delay, it would be a language disorder, a discrepant delay in speech and language development. But as you notice, as we were going through those milestones, babbling came before using mama, dada, came before saying any other words, came before following commands. This child was acquiring the speech and language developmental milestones in the usual order. So there's no developmental deviation here, it's just dissociation. So this child would be expected to have a developmental language disorder on formal testing. All right, developmental deviation is the third problem. And like I said, that's the deviation from the sequence of typical milestone acquisition within any stream of development. And what it means is you actually acquire higher level developmental milestones before accomplishing lower level developmental milestones. And this would be the most atypical, least statistically prevalent problem that you can have with development. So here's our third case, 2-year-old boy fails a developmental screen. And again, the parents are concerned he's not talking. So again, we know the most common reason for that is global developmental delay. Second most common is a developmental language disorder. This would be the third most common. So gross motor, walked at a year, ran at 18 months, just started the jump. That's all perfect. Age appropriate gross motor development. Nonverbal problem solving, scribbled soon after a year. Like I said, that's 16 to 18 months. That's great. Stacks and lines up blocks. That gets them up to 24 months. At 24 months. Imitate strokes, but not in the appropriate orientation. That's also 24 months, but not 30 months. Complete shape sorters, and that's somewhere between 24 and 30 months. So that's really good. And he also recognized all the letters of the alphabet at 18 months. And so at first you look at that and you think, well, that's totally age appropriate, nothing to worry about. And then you think about what is the average age in the United States for children to recognize all letters of the alphabet. And it's actually, believe it or not, 5.5 years. So this is a great skill for this child to have. He's only 2 years old and he's recognizing all the letters of the alphabet. But from a developmental standpoint, it raises the hair on the back of my neck thinking, why is he doing this 5.5-year-old thing before he's, imitating strokes, which would be a 30-month thing, or maybe reversing shape sorters, which would be a 30-month thing. So this is a older level milestone that's occurring before younger level milestones. And so it just, makes you concerned that this may be developmental deviation. Before anybody asks a question, I've seen those infomercials at 3 a.m. where you see little 9-month-old babies reading flashcards. I don't know how they do it, but I think if you really can drill babies very early on, you probably can teach them letters of the alphabet early. So this may be nothing. If the parent says they use one of those programs, they hold up the word chrysanthemum, and their 18-month-old baby reads it. But that's not the typical thing. Usually when we get this history, what the parents say is, I didn't even know they could recognize letters, or they taught themselves. They have a real interest in letters, not that they really drilled them on it. So, this may not be anything, but from a developmental standpoint, it does raise the hairs on the back of my neck that this is developmental deviation. And again, that's the most atypical thing you can see in development. Then we go to speech and language, started babbling at a year, just like the first two. That's a 6-month-old thing coming along at 50% the expected rate. But this child has a 5-word vocabulary, but includes the names of all colors. And that's a 3-year-old skill to be able to name colors. But he doesn't use a specific mama and dada to refer to his parents. So that's a 10-month skill he's not doing. And he's doing a 3-year-old skill of naming all the colors. Again, very developmentally deviated. That's a really unusual thing to see. Also is not calling mom or dad, but he repeats phrases from videos. And to put 3 words together would be a 3-year-old thing. So he's doing that, but not a 10-month-old thing. He doesn't use gestured language, pointing, waving bye-bye. That would be a 9-month-old thing. So this, and he just started following gestured commands, which is a 12-month-old thing, but not ungestured, which is 16 months. So when you add visual to it, he does a little bit better up to 12 months. But this child is definitely delayed in his speech and language. He's not using gestures. He's just started following gestured commands. He's not using mama, dada. Although he does have this deviation up to a 3-year-old level in naming colors and repeating phrases, but those are probably not very functional things, and they're not using communication for social interaction. So this child is delayed in his speech and language development. His speech and language development is dissociated from the rest of his development. The other 2 areas are not delayed, but he's also developmentally deviated, acquiring skills in the wrong order in both his speech and language and his visual problem-solving development. So chances are when we do the evaluation of this child is likely to have autism because of this dissociated and deviated developmental pattern. He's processing information in a way that's different than most other kids. And if you're processing information in a way that's different, chances are your interests and your behavior are going to look different. So this is the way we like to teach about how to think about autism. So once we know that pattern of developmental delay, dissociation, and deviation, the next step is to make a developmental diagnosis. And what I alluded to earlier, developmental diagnoses really have 2 components. There's the etiologic diagnosis, what's the medical cause, and then just the descriptive diagnosis. Because like I said, no 2 kids with autism are the same, no 2 kids with intellectual disability are the same, no 2 kids with cerebral palsy are the same. They're all descriptive diagnoses. And this is sort of just like a cartoon about how we think about that. The etiologic diagnosis comes about because of an interaction between neurobiologic factors and environmental experiences. And the primary etiologic factors are the genetic and epigenetics. And the environmental experiences really can influence your genes through epigenetics. And Dr. Murali will probably be talking about that. But anyway, it's this interaction between neurobiologic factors and the environment that really wires your brain. And I just use this term CNS connectivity. It's really how your brain wires. And the way your brain wires determines your motor development, your cognitive or central processing development, and your neurobehavioral development, which are the 3 parts of Caputi's triangle, which I'll talk about in a second. And so once you map the motor development, the neurobehavioral development, and the central processing development, then you can make the descriptive diagnosis of a developmental disability like intellectual disability, autism, cerebral palsy, learning disabilities, ADHD, or minor motor incoordination like dysgraphia or dyspraxia. So every child with a developmental diagnosis also has an etiologic diagnosis. Unfortunately, we don't always determine, especially the more mild the developmental problem, the more unlikely we are to determine the etiologic diagnosis, but it doesn't change the developmental diagnosis from a descriptive to an etiologic diagnosis. The developmental diagnosis is always descriptive. So that's a picture of Arnold Caputi. He's like the grandfather of developmental pediatrics, set up the first developmental pediatrics fellowship program at Johns Hopkins in the 1960s. And I like his model because he makes development very easy. He breaks development down just into 3 streams. And you just saw them on the last slide: motor, central processing or cognitive, and neurobehavioral. And you can break each of these streams down into substreams. So the motor stream is really made up of gross motor, fine motor, and oral motor, speech and feeding. The central processing is basically verbal and nonverbal reasoning. But these 2 areas of language and visual problem solving actually come together to determine your social central processing as well as your adaptive skills. But your social skills are much more dependent on language and less dependent on visual problem solving, whereas your adaptive skills, which are like feeding, dressing, and so forth, are much more dependent on your nonverbal, fine motor skills. And then neurobehavior isn't, when we talk about neurobehavior, it's not learned maladaptive behaviors like having a tantrum or being disruptive. It's sort of your, behavior that's in your wiring, your ability to pay attention or your activity level. And really all of psychiatry goes into the neurobehavioral domain. So once we know what the domains of development are, and we know the 3 problems that can occur with development: delay, dissociation, and deviation, there's also 3 primary neurodevelopmental principles that we apply. The first is that there's a spectrum of disability within each stream. So the corollary of this is mild disability predominates over severe. So there are a lot more kids who have mild cognitive problems than severe cognitive problems, and mild behavioral issues versus severe, and mild motor problems versus severe. And like I said earlier, this is one of the reasons why the prevalence of autism has gone up, in that, 40 years ago, we weren't diagnosing the much more prevalent mild kids with the diagnosis of autism. The second neurodevelopmental principle is there is a continuum of disability across streams. And we hit on that earlier too, that diffuse developmental dysfunction predominates over focal dysfunction in kids. In adults, focal neurologic deficits are much more common. You have a stroke and you can't move your right arm. In kids, the developmental problem tends to be diffuse across all areas of development. Global developmental delay, fairly equally delay across all domains of development, is the most common pattern. And then the third principle we also kind of touched on, but increasing developmental dissociation and deviation reflect increasingly atypical development. And so the more atypical the development, the more atypical the behavior should be expected to be. So these are our 3, we have our 3 problems with development, our 3 streams of development, and our 3 principles of development. So now I have some cartoons going through every developmental diagnosis, so you know where autism fits in there. So I don't know why there's a blue square already, but this would be the spectrum of a global central processing delay or global cognitive delay. So we're just looking at that central processing cognitive stream of development. And at the unaffected end, you're going to have age-appropriate central processing or cognitive development. Your verbal, nonverbal, social, and adaptive skills are all age-appropriate. And with global delay across all those different parts of cognitive development, you're going to get a mild cognitive delay or be a slower learner. Your intelligence quotient would be less than 90. That would put you in the low average range or below. And a lot of people argue, is this really a developmental problem? But kids who are below average really do struggle in regular schools, and it really is the most common referral to a developmental pediatrician is this type of learning problem. It affects 23% of the population. And then as your delay becomes more global, then you reach a level of intellectual disability. And I alluded to this earlier, an IQ less than 70 would be considered intellectual disability as long as the adaptive behaviors were also below 70. And again, remember that first developmental principle that mild cognitive delay is much more common than severe. 23% of kids will be below average, but only 2 to 3% will have intellectual disability. So now if we start again with a child with age-appropriate cognitive development across all streams, and we only look at a spectrum of dissociation and deviation. So in this case, not all these cognitive skills are going to be affected equally. So this would be less common than being globally delayed. Remember, mild global cognitive delay is 23% of the population. So this is dissociation. So first, we're going to look at dissociation in the language stream of development. And language has 5 components, and I don't have time to talk about all of them. But one of the components is phonology. And what phonology really, when you have a problem with phonology, if you have a dissociated delay in phonology, you have trouble sounding out words. And what that leads to, you can't associate the sound a letter makes with the written symbol. And so that's what dyslexia is, or dysphonetic dyslexia. 85% of kids with dyslexia who can't decode words have trouble with phonology. But most kids with dyslexia, the rest of their language is fine. So really their only problem is they can't read, they can't decode words. But if you played a book on tape, they would understand it because all the rest of their language is developed age appropriately. So that would be the mildest end of a discrepant delay in language, is you just can't sound out words. But as more parts of your language become dissociated, and it's not just phonology, it's morphology, syntax, and semantics, which when all of those are diffusely delayed, it actually affects your verbal reasoning, and your verbal IQ becomes dissociated from your nonverbal IQ. And we refer to those kids, if they're preschoolers, as having a language disorder. You know, that would be our example 2 in the cases, you know, dissociated delays in all aspects of language. And these kids have much more difficulty than just not being able to decode words, you know, because all of their language is discrepantly delayed. So a child with a language-based learning disability, it doesn't matter if you ask them to read it or listen to it, they're going to have equal difficulty because all aspects of their language are involved. And then finally, if we reach a point where there's a dissociation in verbal, or let me start again. The last part of language is pragmatic language, the last component of language. And what pragmatic language is your ability to use language for a social purpose. So at the severe end of this spectrum, you have dissociated delays in both verbal and nonverbal pragmatic language. You know, you don't know really how to request something verbally, and you also don't try to get your point across non-verbally. So both your verbal and nonverbal skills are dissociated, and you also see deviation in language. So what I showed in that example, you're not saying mama, dada, but you're naming all the colors. And so at the severe end of the spectrum, we use this term social communication disorder, because at the severe end, you have this dissociated pragmatic language. Your social use of language is discrepantly delayed from the rest of your language. But in this spectrum, you also have all the other language problems. You have both a social communication disorder and the language disorder. So this is the cognitive or central processing component of what we see in what used to be autistic disorder and what is now autistic spectrum disorder with a language disorder. Okay, so now we're going to go to sort of a mirror image problem in that we're going to have a dissociated delay in orthography, which is a nonverbal part of your development. And these kids also have dyslexia. These are the kids, they can sound out words fine, but they forget which way the B's and the D's go. And for whatever reason, this is much less common than phonological processing, you know, the dyslexia we talked about before, where you can't sound out words. About 85% of kids with dyslexia have phonological processing disorder. Only about 15% have what used to be called dyseidetic dyslexia. But again, it causes the same problem. It's a difficulty with reading, decoding. But again, a child with dyslexia, if you give them a book on tape, they'll be able to understand it. So it's an isolated delay in reading. But as more aspects of your visual problem solving become affected, you actually reach a point where your nonverbal IQ becomes lower than your language IQ. And we refer to that as a nonverbal learning disability. So those kids, rather than just having trouble remembering which way the B's or D's go, they have trouble with handwriting. They can't copy off the board. They have trouble with drawing. They have trouble with the right and left orientation. They can't tell time on a clock. They have trouble with geography and geometry. You know, they get lost in familiar places. So it's a much more diffuse learning problem, and you know, less common than just dyslexia. But when you think about it, part of your social communication is nonverbal. You know, if a kid, you know, doesn't have the language, just think of somebody who doesn't speak your language. They try to do everything they can non-verbally to get the point across. They're pointing, they're using facial expression. So at the severe end of this spectrum, you have dissociated delays in those non-verbal parts of pragmatic language. And so you also have a social communication disorder. But the difference is that these kids have a whole lot to say, but they just don't know when to say it or how to say it to communicate socially. So an example of this would be a kid who can tell you everything you ever wanted to know about the French and Indian War, but has trouble asking if he wants another piece of pizza or you know, some more social type of thing. So this is the cognitive or central nervous system processing problem that underlied what we used to call Asperger syndrome. So kids with Asperger syndrome are actually very good verbally, but very bad non-verbally. So when they get stuck on something, it tends to be something verbal. They're good at that. So they'll tell you about the French and Indian War or dinosaurs or baseball statistics or train schedules. Whereas a child with autism, they're much better visually. So when they get stuck on something, they're lining things up, sorting things out, those kind of visually perceptive behaviors. So this is the spectrum of dissociation and deviation. And remember, that's more atypical than global developmental delay in cognitive development. And if we look at the neurobehavioral stream, again, we'll start with age-appropriate neurobehavior. And if we have a dissociation, you know, we have inattention. And really, that's what ADHD is. It's a dissociation between your cognitive abilities and your ability to attend. So it'd be a 6-year-old who attends like a 2-year-old. That's a dissociation. That's inattention that we see with ADHD. But your inattention could be deviated as well. It can be more atypical. And at the severe end, you have very atypical attention, where you can't look at somebody in the eye for a second, but you can sit there all day long watching something spin around, or you don't notice, you know, a sound in the distance, but you're totally bothered by the tag on your shirt. You know, you either overfocus or don't pay attention to sensory input, that sensory hypo or hyperresponsiveness. In developmental pediatrics, we really look at these kind of things as an atypical attention. In the DSM-4, you could not diagnose both autism and ADHD. And I actually sort of like that, because in my mind, every kid with autism is going to have these atypical attentional symptoms due to their atypical, again, less statistically prevalent cognitive dissociation. And you can think of the same thing for the excessive motor activity. You know, kids with ADHD are kind of fidgety, but kids with autism are more atypically fidgety, you know, the stereotypic motor mannerisms. So it's all a spectrum. And it also goes to show you how hard it is sometimes for us to make a diagnosis, because is it just ADHD with some social difficulties, or is it really a mild autism with some hyperactivity? So right now, up to now, I just talked about the different streams of development and the spectrum across the different streams. But remember, there's also a continuum. So developmental problems in one area are most often also seen in other areas. So again, we'll start with a child who has age-appropriate cognitive development, age-appropriate neurobehavioral development, and age-appropriate motor development. And if we're just globally delayed, you'll have a kid with mild, low average abilities. Their behavior usually reflects their abilities, and their motor skills usually reflect their abilities as well. And with increasing delay, the same thing. Kids with intellectual disability, their behavior usually reflects their developmental age. So a 6-year-old, a 6-year-old who's developmentally at a 3-year-old level, who pays attention like a 3-year-old, doesn't have ADHD, because that behavior is commensurate with their abilities. And for most kids with intellectual disability, their motor skills early on may be better, but usually over time are commensurate with the rest of their abilities. So that's global delay. That's the most common thing. Remember, 23% of the population would be below average. But we also can have a continuum with dissociated and deviated development. So again, we start out with age-appropriate cognitive development, age-appropriate behavior. If those things are dissociated, we get a learning disability and ADHD. And we know those things commonly run together. It's approximately 50% of kids with ADHD have a learning disability, 50% of kids with learning disabilities have ADHD. And actually, I don't have it on the slide, but both of those groups of kids are much more likely to have motor and coordination too, handwriting problems, clumsiness. And when I went to medical school, they called this mild but diffuse dysfunction minimal brain dysfunction. That sort of went out of vogue for many good reasons, but that was the term that was used to describe these kids with LD, ADHD co-occurring. But again, if you have more dissociation and more deviation, you're going to get that social communication disorder at the severe end. And that's usually accompanied by the more atypical neurobehavioral pattern. And that's what the DSM-4 called pervasive developmental disorders, this combination of social communication disorder and atypical behaviors. And so that's how we think about autism. You know, right now we would replace that PDD with autism spectrum disorder. So here's your final exam. We're going to run through the entire spectrum and continuum of developmental pediatrics. And if you understand this, I think you should be certified as a developmental pediatrician. Currently in the United States, there's 19 million kids under the age of 19 with a developmental disability, and there's less than 750 board certified developmental pediatricians. So there's a desperate need for people who do what we do. So I always say, if you understand this slide, you pretty much get what we do. So we start out with a kid with age-appropriate cognitive development, age-appropriate behavior, age-appropriate motor development. If we're delayed, you're usually mildly delayed. More severely delayed, you get intellectual disability. If instead you're dissociated, you get a learning disability, ADHD, and these mild motor coordination problems. You can be dissociated and delayed, that's possible. But as you get more deviation is when you get to the social communication disorder and those atypical attention and motor responses. CP would be the most dissociated and deviated motor response. And you certainly could have intellectual disability with dissociation and deviation. Like I said, 30 to 40% of kids with autism will have intellectual disability. And then autism really sits here. It's that combination of the social communication disorder, and the and that atypical behavior. But again, you expect to see that behavior that looks different when you're processing information in a different way. So my conclusions: autism is a descriptive developmental diagnosis within the spectrum of developmental disabilities, not just a simple checklist. No two kids with autism look the same. Children with autism most commonly present with an atypical developmental profile, again, statistically atypical, dissociated delays and deviation. And atypical development or different development is usually accompanied by atypical or different behavior. And since autism is a developmental diagnosis and not an etiologic diagnosis, as development changes, behavior can change. So some kids really make a lot of gains, but outcomes are extremely variable and it's really hard to predict. So when we see the younger kids, we always recommend the full court press of intervention because we don't know which ones are really going to respond and which ones aren't. So that's all I had, and I'll switch it. Let me stop my share so I can switch it to Dr. Murali.
Thank you so much, Dr. Voigt. That was incredible. And I think there will be questions afterwards. This was really fascinating. And I'm pleased now to introduce Dr. Chaya Murali. Dr. Murali is an assistant professor in the Department of Molecular and Human Genetics at Baylor College of Medicine. She received her medical degree from Baylor and went on to complete her pediatrics and medical genetics training at the Children's Hospital of Philadelphia. Dr. Murali is a pediatric geneticist who sees patients at Texas Children's Hospital in the general genetics and the skeletal dysplasia clinics. Her research is focused on the psychosocial implications of genetic diagnoses for patients and their families. And in addition to her medical and scientific work, Dr. Murali is a personal essayist whose writing has appeared in several publications. She's interested in hearing and telling stories. So Dr. Murali, please take it away.
Let me just get my screen set up here. I'll be sharing. Okay, so y'all should be seeing my PowerPoint screen now. Perfect. Okay, so thank you, Dr. Voigt, for that really educational talk. I learned a lot listening to him as well. So I hope that you guys will find my talk as well kind of equally informative. I'm going to be talking about genetics and autism spectrum disorder. And as you might imagine, both of those topics are huge and we really can't cover everything in 30 minutes. But I'll try to give you a general overview here. And so today we'll go through, first we'll answer the question of kind of how does genetics relate to autism spectrum disorder or ASD? We'll talk about the ways that genetic testing can be helpful for families affected by autism. We'll talk about how autism runs in families. We'll talk about what types of genetic testing may be offered if your child ends up getting testing for ASD. We'll talk about example genetic causes of ASD, just a few, and kind of what lessons they teach us about the genetics of autism. And lastly, we'll talk about how we interpret genetic test results. So it's a whole bunch, but hopefully we'll be able to get through it all. So first, the question is, can genetic testing diagnose ASD? And I think that Dr. Voigt already kind of went over this, but I wanted to highlight this some more because I think it can be an issue of confusion for a lot of people. Things like the ADOS or different types of developmental screening and testing that are performed by people like Dr. Voigt, that's the way that we formally diagnose autism spectrum disorder. So that answers the question of yes or no, does the child have autism? My job on the other side or in the background is to answer the question of why. So if a child is diagnosed with a developmental delay or autism or something along those lines, they would come and see me and I would help the family figure out what testing to send to try to figure out if we can figure out that etiological diagnosis, like Dr. Voigt said, which is really just the why of why the child has ASD or whatever other developmental issue. So then, how is genetics connected to ASD? So we're still honestly trying to understand all the causes of ASD, but there's a lot of evidence suggesting that there is definitely a genetic link. For some people, that genetic link is very obvious, and we'll talk about some of those obvious links that we can find. And for other people, it's more complex. There's many genetic syndromes that can predispose to developing ASD. And of course, diagnosing those syndromes can help us tailor the medical care for the child, but also help the family as well in terms of understanding how it came about and what it might mean for their family's future. Dr. Voigt mentioned kind of that connection between environment and genetics. Unfortunately, I'm not going to be going into that in detail today, but certainly we understand that there's some kind of environmental influence on how genetic predisposition makes somebody develop autism or not develop autism. And we'll talk about later on in this talk about how there's certain genetic causes that have been associated with autism. Just because a person has that genetic cause in their DNA doesn't mean they're definitely going to have autism. And so again, there's that environmental link. We don't really understand the full details of that environmental link, which is part of the reason why I won't be talking about it today. So talking about the genetics of ASD, first of all, like I said, it's not fully understood, but we do know quite a bit about the genetics of ASD, and we do keep learning more every single day. ASD can be a symptom or a feature of a larger genetic syndrome. And in that case, we would refer to it as something called syndromic ASD. So just using the adjective version of syndrome. Isolated ASD can also have an identified genetic cause, and that we would call non-syndromic ASD. This distinction between those two doesn't really matter for the purposes of a family, but it's something that we think about sometimes as genetics physicians. Currently, over 1,000 single genes and 17 genetic regions have been associated with ASD. So as you can see, we have lots and lots of different things that we can test for. And so it's useful to see somebody who's skilled and knowledgeable about genetics. So first, you might be wondering, when it comes to genetic testing, will all kids with autism receive a genetic diagnosis? Or you may be thinking about your own child and say, hey, my child got testing, we didn't get a diagnosis. And that is true that many children don't receive a genetic diagnosis, whether they come for autism or for another indication. It depends on the test that's performed, as well as the patient's clinical features. But if you look at the medical databases and literature, if you take all kids that have autism, anywhere from 3 to 40% receive a genetic diagnosis with our current testing technology. So that number isn't terribly high. There are certain features that make it more likely that a child will get a diagnosis. So those are things like global developmental delay or intellectual disability, like Dr. Voigt was talking about. Children who have epilepsy plus autism are more likely to get a diagnosis. And children who have other medical problems, that syndromic diagnosis that I was talking about. So if the child has ASD plus global delay, plus epilepsy, plus maybe a kidney difference or problem with growth, that child is more likely to get a diagnosis just because of all the different issues that are going on. So then we'll talk about what are the different ways that genetics can cause ASD. So I like to use metaphors as much as possible whenever I'm explaining genetics to people. So hopefully these will be helpful to y'all. So the first idea is the idea of, imagine just one domino, a couple dominoes in a row, one domino gets knocked over, and at the very end, you have another one that's knocked over. That's what we call something called monogenic disease. What that means is we can find one genetic region or specific gene with some type of change in it, whether a spelling change or a change in the location or a difference in kind of whether it's there or not. And that genetic change has a strong effect, and that strong effect goes down that line of dominoes and knocks over the last one, which gives the child a diagnosis of autism. That's called monogenic because it's really simple and we can follow the track very easily from one to one at the end. On the other hand, imagine a set of dominoes set up like this or even more complex, where there's multiple dominoes at the beginning that you have to knock over, and those all can come together in a complex pattern and knock over one at the end. That's what we call polygenic disease. What that means is sometimes for people who have autism or other genetic differences or problems, it might be that there's multiple genes or multiple genetic regions with subtle changes that either our testing technology can't pick up or it's just not trained to pick up. And those subtle changes can add up to give a person autism or give a person another diagnosis. Unfortunately, right now, our genetic testing technology is really, really good only at monogenic disease. We're learning more and more, and we're starting to get polygenic types of testing available for certain things, but we're definitely not there for autism. So then let's talk about, when we do genetic testing, who can genetic testing help? And so imagine that this is a family with a child with autism, and this is the boy who has the diagnosis. And so if we do genetic testing for him and we discover a genetic diagnosis, it can help him because we might be able to tailor his medical care. It could also help mom and dad because it could help them understand why their child has autism, as well as what other medical issues that may arise in the future, and also help them understand, are we going to have another child with autism or what are the chances of that? And it can also actually help unaffected siblings because they themselves, as they get older, they may be wondering, am I at risk or do I have a chance of having a child who has autism? And what does that mean for me? So if we find a genetic diagnosis in a particular child, that can actually affect the whole family. You might be wondering, okay, so how does genetic testing help? We talked a little bit about things like family planning and chances of having another affected child, but another way it can help is for the child themselves. So say we find a genetic difference in a child that explains their autism, but I look at the medical literature and I find that, children with this genetic difference, they might also have a difference in their kidney shape, or they might have a difference in their heart structure, or they might have seizures in the future. We'll know to look out for those things. So we can do imaging for the kidneys or the hearts. We can say, hey, if you have this unusual movement, let's have you see a neurologist. So those are the ways that we can actually tailor medical care if we're able to identify a genetic cause. So not talking about how does genetic testing help beyond the patient themselves. For families, sometimes finding a genetic cause for autism can help us reduce guilt in the parents. And so they may feel like, I didn't necessarily cause this. It was something that was caused by my genetics or the child's genetics, and I don't choose what genes I pass down to my child. And so it's not my fault. It can also help people improve understanding. So of course, everyone asks when their child has any type of medical problem or issue, why this happened. If we find the genetic cause, having that why and knowing it can also help us feel better, but it can also help us know what can we do to help our child in the future. And lastly, it can help us find support. So say, you have a child who's diagnosed with autism and you meet families of other children with autism. But if you have a child diagnosed with a particular genetic disorder, it may be even more detailed or specific to talk to families who have other children with the same genetic disorder. And so that can help them, you can connect on good specialists to see or things that work for your child and so on. And so finding that support can be really meaningful for children with any genetic diagnosis. So I've kind of tooted the horn of genetic testing and talked about all the great things about it. But I will admit there's some limitations for genetic testing, especially in the context of ASD. For now, most genetic disorders, especially those that involve brain development and function, don't really have a cure. And so we might be able to say this is the genetic spelling change, or this is the part of the genetics that's missing, but we can't go back and fix that change in a child, or we can't go back and re-add that genetic difference that's missing. So unfortunately, we're not there with that technology. There's only a very small handful of genetic syndromes where we can do that. And we're not really there with most syndromes. In fact, as far as I know, all syndromes that cause ASD. The other thing to keep in mind, and I kind of talked about this earlier, is that if we find a genetic change that is associated with ASD in a child, and that child has ASD, we could go on and test the other family members, like the parents and the siblings and so on. But we might find that a parent has that same genetic change, they don't have ASD. And we might also find that, say, a younger sibling or an older sibling has the same change, and then we become worried, do they also have ASD? Will they be diagnosed with it? And we can't always use that genetic spelling change to predict it. It turns out that most genetic spelling changes or genetic differences that give a child a diagnosis of autism, what they really do is just increase the risk. And so we can't use that change as a proxy for the autism diagnosis. You really still need to see someone like Dr. Voigt to get that developmental testing. Now talking about how autism runs in families. And so these are kind of some raw numbers that I threw up here. There's a lot of folks who are studying, if I have a sibling with autism, what is my chance of having autism? If I have a parent with autism, what is my chance? And so on. And so these are some numbers that I found from a fairly recent paper. And they looked at people, I think, across multiple countries, a very large study. And they said that people who have a full sibling with autism, their chance of having ASD. So if I have autism and my brother or sister has it, or excuse me, yes, if my brother or sister has autism and I do not, or I'm just here, the chances of me having autism is 10 times higher than if my brother did not have autism. I hope that made sense. What I was trying to say is, if you have a sibling with autism, your chance of having ASD is 10 times higher than if your sibling didn't have autism. The chances of developing autism kind of decrease a little bit when we have half siblings, right? And that kind of makes sense because you only share less of your DNA than if you were full siblings. And it decreases even more when we come down to cousins. There's a lot of papers out there about this, and these numbers just kind of tell us a general risk, but it doesn't necessarily, again, give us the diagnosis. So now talking about what we know about ASD among siblings. So this is something that y'all might be wondering. What we know for certain is that if you have an older sibling with ASD, you have a higher risk for having ASD yourself than if you don't have an older sibling with ASD, or if your older sibling is healthy or you don't have one at all. If you have multiple older siblings who have ASD, then your risk or your chance of having ASD is higher than if you have only one older sibling with ASD. And lastly, as many of you probably are aware or might have experienced, for reasons that are, again, not fully understood, men or boys are much more likely to have ASD than women. Again, we don't really understand that. But it turns out that if you have an older sibling with ASD who's a girl, the chance of you having ASD is higher than if that older sibling was a boy. We think there's something to do with the genetics and kind of it's harder for women to have ASD, so there must be a stronger genetic component in that family. And so that's why if a girl has ASD, the younger sibling has a higher risk than if a boy has ASD. And then the other thing that goes along with it is that if your older sib is a girl and she has ASD, and you're a boy who's the younger sibling of that person, your risk is higher to have ASD than if you're a girl. And again, it's having to do with it's easier for boys to develop ASD. And so a genetic difference or genetic combination of genetic differences in a family might give a boy ASD where it may not kind of predispose or tip over that girl to having it. So now we've kind of talked about genetics and the relationship with ASD and how we kind of understand it. And now we'll talk about what types of genetic testing could be offered if you end up going to see a geneticist for ASD. First, I'll kind of take a step back and talk about genes and genetics in general, because I know that this is a topic that's pretty foreign to most people, so I want to make it as easy to understand as possible. So first, I always tell people that genes are like recipes. They tell our bodies how to make all the different parts of a human, and we contain all those instructions inside of us. Humans are complex beings, and so it turns out that we have 20,000 recipes total throughout our bodies that say, here's how you make all the parts of a human being. Now, since we have 20,000 recipes total, you have to imagine they have to be organized or arranged somehow. And they're all organized into cookbooks that we call chromosomes. And we actually have 23 pairs of chromosomes. We get one set of every single cookbook or recipe from mom, and one set of every single cookbook or recipe from dad. And they come in pairs, and we have 23 pairs total, because that's just the number that humans have. And so it's almost like you have a family recipe for every single gene or every single part of a human that needs to be made. So mom's version of chocolate chip cookies and dad's version. If you look at them, you can say they're both recipes for chocolate chip cookies, but then you'll notice subtle differences, maybe in the amount of sugar or the spices that are put in and things like that. So then talking about the actual types of genetic testing that are available, the most broad or kind of zoomed out view you can take is you can just take a step back and look at all the bookshelves and just say, okay, there's 2 bookshelves here, one from mom, one from dad. Let me just make sure that the correct number of cookbooks is present. And that just counting, it's very kind of zoomed out, like I said, that test is called a karyotype. So you can see here on the right side, you have these kind of long, skinny lines that represent all our numbered chromosomes. And they're coming in pairs for every single chromosome, because like I said, one from mom, one from dad. So that's the most broad and zoomed out test that you can do. You can zoom in a little bit further. You could take every book off the bookshelf. You could flip through the pages and you could say, are there any missing or extra pages of genetic material? And that, like this image here, kind of you see ripped out pages. That kind of test is called a chromosomal microarray. So it's a big term. We usually abbreviate it as CMA. But what it just means is we're looking through all the genetic material to see if there's any missing or extra chunks. Though even more zoomed in, you can say, I'm going to look at every single recipe or a couple of recipes or a handful, and I'm just going to look and see, are there any spelling mistakes in these recipes? And so you can see here in this recipe for sugar cookies, there's a big spelling mistake here where the underline is. And that type of testing is called sequencing. So there's actually the genetic code is actually made up of multiple letters. And we can go in and we can kind of spell check the genes to make sure they're spelled how we expect them to be spelled. So the most common genetic tests that kids with ASD usually receive are chromosomal microarray, that test looking for missing or extra chunks. Fragile X testing, which we'll talk about a little bit more later on. And whole exome sequencing. So whole exome refers to all of the genetic material, and sequencing again is that spell check of the genes. And so most of the time, kids with autism, usually what people will offer, the first test is chromosomal microarray. Many people will also do Fragile X. And then if those tests don't give us an answer, a lot of us now are moving towards whole exome sequencing to try to spell check all the genes, to try to see if we can identify a spelling change that causes the ASD. So I know we've covered a lot here, and I promise I won't go into too much more detail about these syndromes, but I wanted you guys to learn a little bit about some example genetic syndromes that can be associated with ASD. And so those are Fragile X syndrome, which is shown on the left here, 22q deletion syndrome, and 16p11.2 deletion syndrome. And so these are all different genetic changes that can cause a child to have ASD. And I'm not going to teach you about the syndromes themselves because that's not the purpose of this, but I want us to think about what these syndromes can teach us about the ways that autism is linked to genetics. So let's first talk about Fragile X syndrome. So Fragile X is a condition where you have basically, there's a gene on the X chromosome, and it's almost like a bunch of extra letters were stuck in there. So it's like somebody fell asleep on the keyboard and just pressed the Z button a bunch of times. And so the gene, as you can see down here, it's a little bit hard to see, but you can see how there's this little skinny section that looks fragile, right? And that fragile skinny section is because of that extra Z, all those extra letters that are put in there. And so this particular syndrome, like I said, is located on the X chromosome. So most of the time, women who carry Fragile X syndrome aren't affected by it, but they can pass it down to their sons, usually their sons, and those sons can then have Fragile X syndrome and can also have autism as a result. The thing to remember about Fragile X syndrome, one is that, like I said, it can affect boys more than girls. And the other thing is that you have to be thinking about Fragile X to send the right testing to diagnose it. And so again, it can be useful to see somebody who's really thoughtful and trained in genetics so that you make sure that your child gets the appropriate testing. Because all the other tests we talked about, the chromosomal microarray, the whole exome sequencing, those won't pick up Fragile X syndrome. And so that's something to keep in mind. So talking about 22q11 microdeletion syndrome. So the things I want you to learn about this syndrome is that kids with ASD can have parents with different or very minor medical issues. So this particular syndrome, you can see this child here has some unique facial features, although some people with 22q deletion syndrome have very subtle difference in facial features or maybe even not noticeable at all. Some people with 22q11 deletion syndrome will have differences in their heart structure, differences in their kidneys, and so on. But some will just have minor learning disability and not really know that they have it. And in fact, it's not uncommon for a child to be diagnosed with 22q deletion and then a parent to be diagnosed because they pass it on to their child, but never have known that they had it. And 22q can cause autism in some folks, so it's something to keep in mind. And lastly, 16p11.2 deletion syndrome. The thing to learn about this particular syndrome is that some genetic causes of ASD can have different effects in different people. And so in the same exact family, multiple people might have the deletion. One might have mild developmental delay, another person may have ASD, another person may have obesity, or another person may have seizures. And so this is one of the tricky things that can happen in all of genetics, but seems to happen particularly in autism genetics, is that the same genetic change in the same family can have different effects. And so you have to be very thoughtful in being sure that you're not missing anything when you're thinking about what genetic causes could be at play. So now I'll briefly talk about the process of genetic testing for those of you who may or may not have kind of gone through it. So first of all, a medical professional will decide to send testing. Now, it is true that these days people can kind of send genetic testing from like 23andMe and stuff like that. But a lot of times those tests that are available to you kind of through mail order or online are not as specific and directed as they should be done by like a professional. So I would encourage you, if you've done that kind of testing and you think that's sufficient, it might be worthwhile to have a professional take a look and make sure that everything that should be done was done. Once a medical professional decides to send testing, we usually obtain insurance approval. Now that varies from case to case and country to country, but usually we have to clear it with the insurance to make sure they'll pay for it because it's a pretty expensive test. After we get that approval, we ask the child to either give a blood sample through a blood draw or even a saliva sample. So it's like a fancy Q-tip, you can swab your cheek, send it off to the lab. The lab will run the test and it takes, weeks, sometimes months to come back. And once those test results come back, your same medical professional will interpret the testing and explain it to you. So you might be wondering, what does it mean to interpret genetic testing? So that's kind of everything that we're trained to do in terms of looking at the change, seeing if it fits with the child's medical problems and so on. But let's talk about how we interpret genetic testing results specifically in terms of ASD. First, like I said, if you find a genetic change that may cause ASD, it doesn't necessarily diagnose the child with ASD. On the other hand, if we don't find a genetic cause for ASD, it doesn't take away the ASD diagnosis. And so, like I said at the beginning, Dr. Voigt and his colleagues will be deciding yes or no if the child has ASD. And our testing is trying to figure out why. And if we figure out why, then that's great. And if we don't, that doesn't take away the diagnosis. The other thing to keep in mind is that not finding a genetic cause, it doesn't mean that there's no genetic component. It might just be that our testing technology and our knowledge about genetics is just limited and we aren't able to figure it out. And the last thing to keep in mind is that if you're confused about the genetic test results for your patient or for your child, it's useful to talk to a geneticist about it. So what happens if your child's genetic testing is negative? You probably are wondering about that. So remember back at the beginning, we talked about those dominoes. So you can have one domino at the very beginning, one strong genetic change that tips over a few more and then results in autism. Or you can have multiple dominoes at the beginning that have minor changes, but all those minor changes come together and knock over that final domino and cause autism. And so, like I said, what we're really good at right now is monogenic changes or simple, strong, one genetic change. We're not smart about detecting multiple small genetic changes that add together to predispose someone to autism. And so if your child's testing is negative if your child's genetic testing is negative, the likelihood is that your child probably has a polygenic cause of autism. And in fact, most people who have ASD usually do have a polygenic cause. And as Dr. Voigt mentioned, there's probably some interaction with the environment, but we really don't understand how that all works together right now. And the other things to keep in mind, if your child's genetic testing is negative, the doctor might recommend more genetic testing. So maybe they just started with the chromosomal microarray. They might say, let's do the Fragile X, let's do the whole exome sequencing. There may be more to do. They may recommend repeat testing in the future. And so tests like the whole exome sequencing, they're limited by what we know about genetics right now. So I told you earlier today that, we have 20,000 genes in our bodies as humans. Right now, we know what maybe 4,000 or 5,000 genes do in terms of causing human disease. And so every single day, new scientists and researchers are publishing new papers and saying, this is a new gene for autism, that's a new gene for autism. And so maybe in a year, maybe in 2 years, we can ask the lab to look again at your child's genetic testing to see if anything new pops up based on what we know more about genetics. In the future, new types of tests may be available. So I've talked about tests that we use commonly right now, but there's tests like whole genome sequencing that are starting to become available. And in the future, there's probably more and more testing types that may be available. So if your child's testing was negative at some point, it might be worthwhile in the future, maybe not right away, but maybe in 2 years, 5 years, 10 years, to go see a geneticist again and say, is there more testing we can do now? And lastly, if your child's genetic testing is negative on the clinical basis, we may be able to do research-based testing. So I talked about how every single day we're publishing new papers, well, not me personally, but the genetics community are publishing new papers about causes of autism. And how they're doing that is they're taking groups of children who have autism and they're reading through all their genetic material with a really fine-tooth comb. It's a little bit more detailed than we're doing on the clinical side. So if any of you might be interested in participating in research-based testing for autism, you might be interested in something called SPARK. So SPARK is a nationwide effort that's, throughout the United States, that is taking families and children with autism or adults with autism and trying to figure out genetic causes that haven't been identified yet. So you can see here all the kind of all the inclusion criteria that you have to kind of check in order to participate. And if you're interested, you can actually go to this website, www.sparkforautism.org/Texas Children's. And there's a location for the SPARK study here at TCH. So if you're located in Houston, it could be convenient. But in fact, if I'm not mistaken, they just mail you a kit at your house. And so you don't have to be located close to a center in order to participate. So lastly, I'll end with some overall take-home points. So first, if your child has ASD, it's a good idea to get genetic testing. Once your child has genetic testing, it's important to discuss the results of the testing with a professional who's trained in genetics. Identifying a genetic cause may help with predicting future health problems. It may assist with family planning, and it may help with finding support or reducing guilt for families. And lastly, like I've said a bunch of times, genetic testing for ASD is not the same as formal developmental testing for ASD. So just keep that in mind and make that distinction. There's a couple of resources here in terms of finding genetic services, which we can probably also put in the chat later on, and also resources for families of children with developmental disabilities. And again, we'll put these in the chat. And I will end there and ask for any questions.
Dr. Murali, and we do have some questions. So let's see, that we can start with the first one, which is what causes regression within autism. And Dr. Voigt, would you like to take that question?
Yeah, that's actually a really good question and somewhat controversial in the field of developmental peds. But approximately a third of parents will present a developmental history of regression in social and communication skills when we get that developmental history for autism. We worry much more if there's a more global regression, involving all developmental skills, particularly motor skills, because that's a red flag for a metabolic disorder or other genetic problem. Something like Rett syndrome, for example. But just so we can get to other questions, I'll say we really don't know why a third of the histories report regression. There are various theories for it, but I'll go on too long if I start.
Still so much to learn within this field, for sure. And the next question is, any benefits of vagus nerve stimulation for autism?
I know that's a treatment for seizures, and any child that has seizures, that can negatively impact your development. The more seizures you're having, the less aware you are of your environment all day. So I could picture, if a child with autism has seizures that can be treated with a vagus nerve stimulator, that both development and behavior might get better once the seizures are under control.
Yeah, I hadn't heard about this before. I Googled it actually, and I found a paper from 2017 in the Journal of Neurodevelopmental Disorders that mentions that, some folks have been trying it in people with autism, but I certainly haven't ever heard of it as a therapy specifically for neurodevelopmental disorders. So that would be new to me.
And the next question is panel testing used for ASD as well, or is that similar to whole exome sequencing?
Yeah, that's a great question. So panel testing, to talk about what that is, so whole exome sequencing is testing all the genes to do kind of spell check on all of them. Panel testing, if we're going back to the recipe analogy, it's kind of like I'm going to check all the recipes for cookies and make sure they're spelled correctly. So sometimes we can have genetic testing panels available for hearing loss, for seizures, and so on. And we'll say, here's the couple hundred genes that we know can cause seizures if you have a mutation. Let's spell check them. So some people do use panels for autism spectrum disorder. It depends on kind of the center you go to, the institution and the doctor. But I think most of us, especially here at TCH, if we're going to go for sequencing testing for autism, we usually go for whole exome. And part of it is because panels are kind of curated and created by the labs, and they're not updated every single day. But every single day we get a new paper about autism, right? So if you're doing whole exome, you're looking at all of the genes. And so it can be a more comprehensive test. And if you're doing a panel, you might miss something new that's recently been described.
Okay, well, thank you. And the next question, and you've gotten several thank yous in the questions too, but this is a man saying his daughter was diagnosed with ASD and they've done CMA, Fragile X, and whole exome sequencing with normal test results. Are there any other tests that might be thought of right now?
Right now, I think you might be kind of hitting the end of the road in terms of clinical testing. If your child's whole exome sequencing was done a year ago or longer, it might be useful to talk to your geneticist about what's called exome reanalysis. That's what I talked about, where we learn new things about genes every day, so they could look again to see, are there new genes that we learned about that did pop up in her exome that we didn't report earlier because we didn't think they caused disease. So that might be worth talking about. There is something called whole genome that's becoming available, but it's very, very new. Insurances really pretty much aren't covering it, so it's hard to get. If you are interested, you could look into the SPARC study, which I think would be a great avenue. It does take a very long time to get results from SPARC, so don't expect it in the order of months, but it's something to do to contribute to knowledge and also to feel like you're moving forward.
The next question is with regards to boys being most often diagnosed, and Dr. Voigt, would you like to discuss that?
Actually, boys are more commonly diagnosed with every developmental disability. And I defer to Dr. Murali whether that, a lot of things that cause developmental disability, particularly intellectual disability, are X-linked. And any X-linked disorder would be more common in boys than in girls. Although I know I still collaborate with, I used to work at the Mayo Clinic with some colleagues there, and we recently published a paper that sort of hints at girls are being missed with autism. So I think boys will always have more developmental problems than girls, but I think we probably are under-identifying girls with the full spectrum of developmental problems.
Right, and that's exactly what the question asker asked. She said, many parents, even educated and rich, ignore their daughters. How do you control for this? And I'm not sure if we can fix society, but I think you pick up on a great point. But I think Dr. Voigt's totally right. It's a combination of, there seems to be some biological aspects to it, but there's something social as well happening here. And for instance, I'm sure you know about this better than me, but I've heard about girls with autism, or excuse me, with ADHD are more likely to be inattentive and not get picked up until adulthood, whereas boys are more likely to be hyperactive, and that's noticed. Whereas, kind of female behavioral differences may not be noticed as much.
Question was asking about the tests and that they can help give the information about the cause and future decisions, but do they give hope of a treatment to improve or treat autism?
That's a great question. And the answer, unfortunately, is right now, no. It is something that is an active area of research, but I have not experienced up to this point, I'm not aware of any genetic causes for autism where we can then go in and fix it or treat it specifically. The only, I guess the only exception to that would be metabolic diseases, which Dr. Voigt sort of touched on. I won't go into a lot of detail, but metabolic diseases are basically genetic differences where they affect the way our body processes energy. And so sometimes if people have a metabolic cause for their autism, we can treat their metabolic disease by special diets or special medications, and that can help get them better overall, and it may help with the autism and the behavior.
And we do have a number of questions, but we are running low on time here and we've gone over. I guess there's one question here. As a geneticist, do you also study genetic duplications, and in particular the 16p11.2 duplication disorder?
Sure, I'll go quick. So I definitely have seen patients with deletions and duplications. So I highlighted the deletion for 16p11.2, but you're totally right that there's a duplication syndrome as well. And for many genetic syndromes where there's a deletion, there's also a duplication. So if your child has the duplication, certainly they should be followed by a geneticist. That's what I would recommend. I don't actively do research on that topic though.
Question is about Asperger's, and I guess Dr. Voigt, you're able to read this too. I've been told that Asperger's is equivalent to ASD, but more recently my pediatric psychiatrist friend told me that Asperger's is not equivalent to ASD, and he says it's more like social communication disorder. Is there something I can reference to clarify this for me and my friend?
Yeah, well, from a developmental standpoint, we really think of autism and Asperger's almost as mirror images of each other. Kids with autism have discrepantly good skills in visual problem solving and discrepantly weak skills in language. So when they get stuck on something, they get stuck on something visual because that's what they understand. That's what they like. Kids with Asperger's, it's just the opposite. They're better in verbal skills and worse in nonverbal skills. So kids with Asperger's syndrome, when they get stuck on something, it's verbal. They're hyperverbal, talking about whatever their area of interest is. The reason that both of those groups of kids behave in an atypical, statistically prevalent way is because they're both dissociated and deviated. And the more dissociated and deviated your development, the more atypical your behavior is going to be. For Asperger's in particular, there's authors Fred Volkmar and Ami Klin, who Ami Klin's now in Atlanta, but they used to be at the Yale Child Study Center together, and they wrote a really good textbook on Asperger's. And they really put forth this idea that every kid with Asperger's has a nonverbal learning disability. So it's really like the mirror image of autism.
Well, I think that maybe we had better call it for the night. I know that we have additional questions, and I'm sorry we can't keep going. Dr. Murali is typing in some answers here, and I think that's great. But I think we've really gone through most of the questions. I'm just trying to see, I guess. So it looks like a couple of these are genetic-based questions, and the final question is about a 21-year-old daughter diagnosed with autism when she was 3. Would it help her sisters that they themselves be tested? And would it help to see if they can pass this to future kids?
So it would be best to actually have your 21-year-old daughter tested if possible. Although I know it can be hard to access genetic services and testing when you're an adult. If you test somebody in general in a family, whenever it comes to genetics, if you don't test the person who's actually affected and you test another family member, you may be falsely reassured that you don't find a change in them, because it could be that you didn't look for the right change. So you'd have to know what the change is that's causing the autism, or whatever the diagnosis is, in the family member who's affected, and then be able to test accordingly. Somebody else had asked about whether, one of my children has autism, the other one doesn't. Would my child without autism be more likely to have children with it? I don't think that that's been studied as far as I've seen. If I find anything like that, I can pass it on to Susan. Maybe she can send it out to the listserv, but I'm not aware of those studies, unfortunately.
These have been fantastic questions. Thank you all. And I really want to thank the speakers. They've done an amazing job. This is complex information and a lot of it, but bravo, you've done a fabulous job. And I also want to say that we have a survey out, and that link has been in the chat, and please fill it out. That will help us plan for the future. We have 2 upcoming webinars, and one on Saturday, February 5th, is going to be on genetic resources and support resources for parents. And so please join us then. And our next Evenings with Genetics webinar on Tuesday evening will be on February 15th for Black History Month. The topic will be race and genetics. And we really hope that you all can join us, because we're going to be talking about perspectives on precision medicine. So thank you all very much. Dr. Voigt, Dr. Murali, thank you. Thank you. And Mercedes.
Thank you all.
You're welcome.
Bye-bye.
Thank you very much. Bye-bye.